we can make it better, but I think that if things aren't deployed quickly, things are going to fall apart for many people. That they're
Mhm.
not going to have good quality health care and access to it. That they're going to have to travel hours and miles in order to get health care. And that's
Mhm.
difficult for people as they get older. So we have to bring health care to them. That's the point. If we don't bring health care to them, we have a more serious problem.
Hey everyone, welcome back to another episode of Activating Curiosity. I am Ryan Ware, and today we're going to talk about a very critical conversation as it relates not only to the construction industry, AEC industry, but as it relates to pretty much every human on the face of the planet. And that revolves around access to healthcare and healthcare facilities that are, not only within large cities, but also within rural areas, and how we go about planning them with healthcare systems, but also how we design and build them. So today I have with me Peter Nicholson, and he is the co founder and CEO and managing partner with modern clinical planning. So, hey, Peter, how are you?
I'm doing well. Thank you for having me.
Yeah, well, I'm looking forward to the conversation. I know we haven't had a lot of time to kind of connect personally, but your post and the things that you were working on really started to catch my attention. And I thought, hey, this might be something that listeners might want to listen to as well. So I'm glad you're willing to be a part of the show. And why don't we kick off? Just tell a little bit about yourself, what you've done in your career and in your past, and then we'll kind of dive into activating curiosity.
Yeah, I help really design and build hospitals. I've been doing that most of my career. I have skills integrating advanced medical technologies. I've worked and managed clinical projects for Harvard Medical School, the Cleveland Clinic, and others. I've worked not only in the Boston area, but also in Abu Dhabi and in Riyadh and in places in the Gulf. Sometimes people call it the Middle East, but really the Gulf, building hospitals there. And in doing so, I've come up to the conclusion that hospitals have become too complex. And we've tried to develop a model that would make hospitals more affordable, easy to build, and which would make them accessible for people in underserved areas.
Yeah, I think it's, as you just described, healthcare and building a hospital. I think most people will understand it, especially as you drive around and watch one be built. They don't see the backstory of how long it took to like plan that, not
Yeah.
only from the owner's side, but the architects and everybody involved. So they just kind of see it going up, and there's just a huge amount of time that spans,
Right.
right?
And what we try to do is we try to, our products are pre designed. So, from that point of view, we really use the word product, saying that our micro hospital is a product that someone can build, they can customize, they can brand it, but we do the heavy lifting behind the scenes. It's a turnkey idea. So, this is a lower acuity hospital, not a high acuity hospital, but we think it has a real role to play in healthcare delivery.
So you've gone through your career, you've spent your career not only in the States, you've done some work, like you said, throughout the world with the Cleveland Clinic and others. Was it that initial problem that you were aiming to solve? Like, was it geared towards, hey, this planning process is broken, or whether you thought it was broken or not, it just that's the biggest thing that we need to figure out? Or were there other little things that you just kept kind of seeing come up as you were designing and planning, like, yeah, we're not addressing this.
A number of them, a number of them. But in building, I think there's a place for large hospitals first and foremost. I do think that with people with multiple diseases and or
Mhm.
complications, they need to go to a sophisticated hospital. but I don't think that that's the way that most people need care delivered. Um, we, in building large hospitals, I saw the complexity. I saw the waste that went along with them, that people were doing the same thing to get an outcome more than once. So they were always rebuilding and rehashing something because it was complex and people did not understand it, or it wasn't in the right sequence of construction.
Hmm.
So, what we saw is that hospitals were taking 4 years to deliver, and
Hmm.
that's
Hmm.
after the design. And in that amount of time, things can change. Certainly, technology changes and
Right.
has to be revamped, but we don't see it as being a good way to deliver care to people. We have a hospital that we believe we can deliver in 2 years' time. So, from the point that we have building permits that we get in the ground, we will have a hospital fully built for people ready for activation, and that made a difference. Now, we try not to we try not to make it a complex hospital. We're not competing with the major hospital, we're complementing. So,
Okay.
we are looking for 80% of those patients that present can be can be served by these hospitals. For that 20% that can't be, people that have serious or more serious issues, they can be treated and transferred. So
Hmm.
again, we see that as making healthcare accessible to people in their own local community. I always joke that, if you're at one of our hospitals, somebody might come see you.
Yeah. I mean, the word accessible is something I was thinking about as you were talking, and just being able to say it is like, one, I think about how many people have to drive hours and hours, staying overnight to go get the care, maybe as you're saying, that would fit into that 80%. So it's about also enhancing individuals' lives, saving
Yeah.
money also in their pocket of travel to healthcare. So there's all these extra costs that humans feel, especially here in the States, that that are healthcare related, but unrelated to actual the healthcare services that you're going to receive by being in a hospital.
Yeah. I mean, accessibility, I think, is tied directly to affordability, first off. We also, I think, as a society in general, aren't really using available technologies very well. And everybody thinks about AI nowadays, and I'm all for it. I think that that can be helpful, but there are so many existing technologies that, if deployed, can help with the efficiency of hospitals, especially smaller hospitals,
Hmm.
allow them to run efficiently and serve the people in the community. This is really where we think we've made a bit of a breakthrough. And it's not using, abracadabra kind of technologies. These are easily found technologies that, if properly integrated in the hospital, they make a big difference for second opinions, remote diagnostics, for people that, you know, need that second opinion, for
Hmm.
OR integration systems where a doctor that's remote can actually see almost everything that's going on in real time in an OR or in a procedure that's going on, so that they can either mentor or support what's going on. And that makes a big difference. I mean, there there are many places where people in the United States are underserved. There are
Hmm.
many places where a phrase that's been used most recently, healthcare deserts, where
Yeah.
people really need to travel, I don't know, 45 minutes to get to a hospital. Well,
Right.
we all know, without being in the healthcare industry, that time matters. If you have a serious condition, if you're hurt, injured, or if you're having maybe a heart attack or something, you know,
Hmm.
time is of the essence. And 45 minutes is a long time. For a small hospital that's affordable, that can be placed in a local community, it's a resource. It's a major resource to that community's well-being, and it can make a difference. We think of our hospitals as being fully deployed with equipment. with over $7 million worth of advanced equipment for $32 million complete in 2 years. I
Mhm.
think that we're seeing this as a delivery method.
There's so much that you just said that, I think a
That's
lot of
right.
directions that we could go. But very intrigued by, well, one, okay, so if we just back up and say, we need to get healthcare more accessible to the patients, right? So it is a
Yeah,
better patient experience. To the affordability side, to get the healthcare system, these hospitals constructed in a timely manner gives them accessibility, not only in distance away from where they are, but quicker, right? Quicker to
right.
market so that you're taking care of the patients. Now you just mentioned, so okay, those things are sort of the problems. That's what you were aiming to solve. And now you just mentioned the delivery model. So talk a little bit about how your delivery model is different.
Well, first and foremost, we see it as a product. Again, it's pre-designed, it's fully equipped, it's built on a turnkey basis so that really the buyer of the hospital just has to make selections on possible options. They don't even need to take options if they don't want. There is a stock hospital that is functional that they can buy for the standard price. Once we
Mhm.
know the options that they'd like in the hospital, we're ready to build. So I think that's the unique. There are a lot of healthcare systems that do deploy micro hospitals, but they
Mhm.
do so as a proprietary uh, facility that they've paid an architect and or engineer to develop specifically for them. They don't sell it to others. Ours
Right.
is a non-proprietary product. And as you mentioned, the timeline. In other
Mhm.
words, it can't be accessible unless it's built, right? Oftentimes, a hospital is built that the shell and core of the hospital is built, and then the equipment is installed.
Right.
And that's a lot of times where things go awry. We installed the equipment as part of the construction process because we know how to do it.
Right.
Not only that, but these are, relatively speaking, in the complexity of hospitals, these are relatively simple hospitals. And that's the 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 value of them because that's what keeps also the cost reasonably low. We don't operate hospitals, we sell them, right? We sell and build them. But in the operability point is that there's not that many healthcare workers. There's always a, a dearth of them in these rural communities where they just don't have people to operate. By
Yeah.
using technologies, we can minimize the number of staff and still maintain high quality standards.
Yeah. So, not only getting the built environment taken care of, but providing a path, thinking about the future labor force, right? Because I think we all know that labor force is changing across all industries. And there is, we talk about the shortage of labor, not only within the construction side and that future labor force, but also in healthcare.
Hmm.
The other area that you're talking about is, hey, you're outside of a city and now you're in a rural area where there may not be either that talent area or development, or someone just doesn't want to live in a rural area that
Yeah, there's
can do a lot of these things, right?
a lot of changing demographics. There are a lot of changing demographics, no question about it. And I believe that 1 in 7 people in America get their healthcare in a rural setting. That's a
Hmm.
lot of people. I think it's something, we're talking about, you know, uh, 25 million people, something
Hmm.
like that. But it's something like 1 in 7. The phrase healthcare deserts starts
Right.
to come into play. It's not only a rural solution. There are plenty of places in cities and towns where there are underserved communities. And
Right.
and these can be, we use a phrase about a hub and spokes. So really the major hospital is the hub, and they can share so many of these technologies that they have at a fractional cost. Whether it's
Hmm.
electronic medical records, whether or not it's a PAC system for digital uh, X-rays and other images, whether or not it's a laboratory information system, whether it's those OR integration and other systems. even AI, telemedicine. These things can be shared at fractional cost. That extra person on the medical records, that's costing nothing. That extra
Hmm.
person that's sitting in a laboratory or looking at these images, they don't have to be in the micro hospital where it's located. They can be remote and it can function very efficiently in that way.
Hmm. I mean, when you say it makes total sense, right? Like healthcare systems to the doctors, like what everybody would want is that affordable, accessible healthcare in a timely manner. And hearing you say it, I can hear having practiced in architecture to being in construction to working for fabricators to even working with healthcare systems, right? Healthcare systems. So I hear having an area of standardization that makes it easier for the healthcare system to go through and design things. And I know I've had an opportunity to work with Kaiser and talk to even HCA and SCA and Dignity or Common Spirits. And like a lot of them wanted to do what you were saying, which was build MOBs to repetitive sort of, smaller facilities, hospitals. But they are proprietary in some instances, which doesn't answer the question I think you're aiming to solve, doesn't provide it to everybody because those are some healthcare systems. So while this isn't new, there are
Correct.
things that have really changed the way we need to think about healthcare design recently. And I always tell the story about the Ohio State University building their major tower here in early 2000s, right? Well, it took, I think it was nearly 10 years to go through planning. Well, there's one thing that didn't exist when planning started and did when it ended, and that's the iPhone. So by
Yeah.
the time they got into the building, as you just described, it's like the building was designed to be something else than where the world was by the time it got in, but everything was designed in a way that didn't allow for flexibility or adaptability as things were changing.
Sure. So
Um,
much changes in a decade. It's amazing. It's amazing.
yeah. Yeah. So what now you're talking about like being able to have these pre-designed kind of concepts for the hospitals. You're changing sort of procurement path and relationships of some of those systems, that not only probably tied to the building and the building automation systems or other things, but also to how doctors will be performing work inside the building. So you're beginning to change that entire delivery process through design, procurement, and construction. So I'm sure you are, this is a mindset shift. So I'm sure you're hearing obstacles to every barrier put up in front of you. So I'm just, curious what some of those are that you're hearing.
Well, yeah, I think that again, we're not the proof of concept is already out there. In other
Mhm,
words, you mentioned one group, healthcare system, Dignity Health. They have their own proprietary micro hospital, and they've deployed it successfully.
mhm,
Uh, and another one, Baylor Scott and White. They have deployed these proprietary themselves. So the proof of concept is there. What
mhm,
we have to prove to people is that MCP can scale, that we can ramp up quickly enough to be building multiple hospitals simultaneously. So the issues that we are faced with are really capital issues, and
mhm,
this is not my bailiwick, so to speak. I'm learning, but access to capital because each hospital. So a hospital is $32 million. Even though we consider that to be a very affordable price, it's still a lot of money, right?
mhm,
And the deposits on things. We have great partners. Our partners are Philips and Getinga and Amico from Canada and other IDA from Ireland and other groups. But like any business, they expect us to give them deposits and they give us
mhm,
favorable terms. Well, if one can do simple math, it said 15% on $7.5 million. Well, that's well over that's $1.1 million just in deposits. So
Mhm.
each hospital needs working capital. And our buyers, they expect to buy a hospital as a product, and that's fair and reasonable. We need to make sure that we can always have enough working capital in order to build multiple hospitals simultaneously. So that's
Mhm.
been one entry barrier that we've had. It's an expensive business, and so we're playing with large entities. And we kind of say, look at the people that are partnering with us because they see that we have a really a viable option to change healthcare delivery.
Mhm.
So they are intended to be simple hospitals.
Mhm.
In a complex world, it's a simple hospital. So that's a barrier. Getting people to speak with us, and getting to the point where we have funding to make sure that people know we exist.
Mhm.
That's why this podcast is so important to me, that it
Mhm.
may help people know that modern clinical planning has a solution that's available to them.
Yeah. Yeah.
So there are a couple of the entry barriers and the challenges that we need to overcome.
So Peter, thanks for sharing that because I think humans we're skeptical. We see fear, like we run from it, and a lot of things that you were talking about are very common with new innovation, especially in the construction industry, because of the way we build. And when we think about, like you mentioned, capital, it's that cash flow through a project. And I think of the part of the industry around prefabrication and, as we're shifting into a lot heavier modular construction, not just in healthcare, but in housing and everything else. Well, the funding structure changes and where the capital has to enter and get to before, you're so far down the line, like that's not new either.
No,
Um, and, just curious, like what other, this is healthcare. So I guess one of my questions would then be, well, if this solution doesn't happen in some of those rural areas, what is the answer from the healthcare systems
well,
to address it?
yeah, it's only part of the answer. First off, right there are
Hmm.
the staffing issues that we spoke about before. That's clearly an issue. Um, we are part of a solution. I think that it can only we can make it better.
Hmm.
Micro hospitals can bring hospital care to people, and we look at to bring healthcare services to people in their local community, and that can be in a city. That can be in an underserved area of a
Right.
city. So, there are a lot of applications, but really we're trying to focus on underserved communities. We
Hmm.
have to deliver. We have to deliver if we want to serve the people of this country.
Yeah, I mean, it's such an important subject to try to get those solutions to individuals, which always comes back to, like you said, the capital. So, I guess the barrier seems to be, you brought it up probably more than mindset in this case, the capital, but I think the capital mindset shift is even part of the process here because if getting them to the rural area and the capital has to change where they're buying a product, the way you're approaching it then, right? The healthcare system, describe that a little more just to try to, so listeners as well as myself kind of understand it. Is it that they're expecting that you're just getting it done in 2 years? There's some deposits that have to happen, but it's not a normal construction sort of progress pay application for what makes it more, I guess, unique a product versus, that traditional method of delivering construction.
So there's a distinction between the buyer, who's not typically an investor, right?
Hmm.
So the buyer wants to buy a product and they're not investing in the operational part of it. The capital issue rests with investment banks, investment arms, with community investment resources, where that's where we need to raise that capital. Two things. One is that a buyer, and the problem of rural health in part is that it's not profitable. And why is
Mhm.
it not profitable? There's a whole host of reasons. There are, low numbers of patients going to specialties. And so therefore there's not enough throughput. And so therefore it's not profitable. Many,
Mhm.
many of these hospitals in rural America are older infrastructure. It's
Mhm.
hard to renovate them. It's a good question about whether or not a renovation should take place or if a replacement hospital should be sought. We
Mhm.
can be that replacement hospital. But, it comes down to the affordability. So we're not going to be able to solve every problem, but we are able to say that we have an affordable, efficient, modern hospital that's available to a community. And that may be much better than dealing with that 30 or 40 bed hospital where people have a hard time maintaining occupancy, for example, in the
Mhm.
hospital. That if you don't have enough patients, they the right scale, it's important to it's not to say it's like a hotel, but a little bit like a hotel. You want to keep your occupancy levels high, but you also want to keep your turnover, something that they call the average length of stay. You want to
Mhm.
have a turnover of your patients so that they're staying, 3 to 4 days, kind of maximum. And that's how a hospital is profitable. If nothing else, a smaller hospital is easier to manage. It's obviously easier to manage. And it's easier to maintain patient volume. These larger
Mhm.
hospitals that are inefficient and older structures, well, they really buildings, as you know, as an architect, buildings get used up. There's
Mhm.
times when they're no longer viable, and we see that when we look at major cities, and the demolition industry is almost as big as the construction industry, right?
Right.
So, well, there can be a point where that rural hospital really has served its purpose and no longer can. And we
Right.
think that these hospitals that are modern, efficient, and sustainable, right, that they become those replacements. Rural
Mhm.
health has these staffing issues. It has the issues of declining populations, but a smaller hospital sits better with those. The buyer, the hospital chain, the hospital system. Well, why aren't they participating? Because they're afraid they're going to lose money. They
Mhm.
don't want to lose money, and so therefore they they don't participate. We're giving them an opportunity to participate because we believe that these hospitals can work, and if they're not gonna be amazingly profitable because they're not amazingly big, but they
Mhm.
have to get out of that mindset. You're not going to lose money. You're going to make a decent margin on these hospitals operating them, and if you have multiple ones, then you can make a bigger margin. But each one of these, as much as they won't make a lot of money, they won't lose a lot of money.
Yeah, so there's, the perspective from the healthcare area and the healthcare system of why would we make this investment if, you know, it's costing us?
If
And on
it's
the
not,
other side, it is costing humans something, right? We've been talking about that affordability and accessibility as being that major problem that you're aiming, to really address. So
yeah.
it, it's an interesting dynamic. Which all businesses have. Where do you spend the money? You know, to provide for your clients or provide for, in this case, the patients. So, okay, so let's just say that they keep looking at from that standpoint. If they don't go this direction, how are they answering that question?
They may
You know,
not. They may
yeah.
not. They don't want to take over that old hospital that's in the town because it's not profitable. So they just demur.
Hmm.
They don't do anything. And then those places at some point in time lose money for some number of years in a row, and all of a sudden they're in the red, and they
Hmm.
can't, and they close their doors. And unless people are willing to use a tax base as a method, that's kind of the old method, if you will, 100 years ago in America. the city hospital, right? That city hospital was supported by a tax base. Only if there's a rural community willing to use its tax revenues to maintain that hospital probably is not going to be profitable and can't sustain losses for a long period of time without closing.
That's why I wanted to have the conversation. We all recognize it. I've always kind of, since growing up, tried to get away from the rural areas because it's just me. I wanted to live in cities and everything's been more accessible. But I have a lot of family that just lived hours from major metropolitan areas that had a healthcare system. I was lucky enough to grow up in one that had a pretty robust one and actually is now going out into other rural areas. In saying that, it's just things that I'm recognizing. And I'm sure other listeners, we all see it, but we get busy and we don't think about it. Well, part of it is like we just don't answer the question. Like you said, the healthcare systems just don't answer it. Doesn't
Right.
solve the problem for anyone. When you're coming and saying, "Hey, this is it's different, but not that different. It's not different enough in a sense of like, hey, we've never seen this before." It's still coming up with a delivery model which sounds more collaborative. You've packaged, you got all of these groups together and said, "Hey, we see this as a problem. Technology pieces recognize it too, like the pain points that they have potentially coming into large healthcare projects and hospitals where they're too late. They're brought in too late and the thing's designed and almost built, and they're probably able to give you, feedback into what would work better, like you're saying, to deliver a better product, a better design, and a better solution, not only for the staff who's there, who is going to be there for a while and dealing with an acceleration of technology and advancement that needs to be able to be switched out and upgraded and continuing to evolve as the industry changes, but also to the patient as they're going through it. So one question I do have out of curiosity as well is, you're working with a lot of solution providers that go into hospitals.
Hmm.
Talk a little bit about just that process of the design. You have pre-designed areas that they could just, purchase as a product like you're mentioning, but let's say they don't want to go to that area. What was the sort of north star for you? Was there a delivery model? We've talked, I think, a little bit about prefabrication or even modular, but like what is it that you're and how you're aiming to build these in rural areas who don't may not even have the contractors and the sub trades to go build them?
Yeah. So what we have is we have a project that has a lot of modular elements. So everything from the skin of the building, everybody's seen these aluminum panels that go,
Mhm,
and that is a really durable skin of the building. We can literally have 3 containers full of this product for the facade of the building. We have modular features in the hospital for the head walls, the foot walls that go in. We have modular ORs that they're not used in America so much. Not sure why, but it's a modular OR. So it's a kit
mhm,
that in fact comes in and builds out the procedure rooms, the even the scrub areas and that sterile core. We in fact have modular features that are down in the head walls in the emergency department. We provide a lot of things that are commonplace to a hospital on a smaller scale. Nutrition services, the
mhm,
laboratory, and one of the things that we've used as a phrase before is a hospital in a box. Um,
mhm,
well, many of the modular elements, it's a full hospital all the way down to pathology, a pharmacy, even, the receiving dock and everything else that goes with that. We've built and designed a hospital with my input, the input of Rob Blake, who's one of the co-founders, the input of others about what are the proper adjacencies, what are the support services that we need, how do we fit this in
mhm.
to a 30,000 square foot building, and And we've been able to do it. And we've been able to do it so that it's efficient, it's compartmentalized, it's safe, it meets accreditation standards. And it was not an easy task at first to do, but we've accomplished it. We always say to people that if they want to buy a hospital, I have no idea what their land looks like. So how do you
Right.
want it oriented?
Yeah.
Uh, that's part of the process when a buyer has their land. We say that we recommend 2.25 to 2.5 acres. That sounds like a lot of land, but there's a lot that goes on between the
Mhm.
ambulance entrances, between staff parking, visitor parking, loading dock, roadways that go around and make the circulation work. So we say 2.25 as a minimum, but recommend 2.5 acres of land. So there was a lot of modular features. These modular features and these elements allow us to build it in 2 years. Plus, our partners, Philips, Getinga, Amico, they come in and they install with us during the construction. We
Mhm.
have to sure things are plumb and square, but basically they put in their head walls. They come in with their CT scanner. They come in with their radiology room and telemetry systems and other things that make the hospital work. So we
Mhm.
work tandem with them. That's how we get to 2 years. The frame of the hospital typically is a reinforced concrete frame. Prefer doing it in steel, but this is an engineer's point of view. But at the same token, we can build anywhere in the world using reinforced concrete. And
Mhm.
so that's how we've designed the building. It opens up if you do it with steel. You know that as an architect, you get better
Right.
span and everything else. But we can build this anywhere in the world and then use modular elements in order to do it quickly, efficiently, and and sustainably. If somebody buys an MCP micro hospital, they're not going to overbuild, right? They're
Right.
not going to overbuild. And that can be a problem. If you overbuild and you don't have the patients, you don't have the occupancy, then you're going to have a hard time with your operating cost. So
Yeah.
with any micro hospitals, at least people will not be overbuilding.
So you've kind of gone through a process of defining a program of requirements, right, based off the most critical and common things that would be required for rural areas that don't have a hospital. You've you're utilizing what sounds like some design assist with specialty technology and equipment so that they're part of that design process and iteration, as well as some prefabrication components, kit of parts through assemblies. So you're utilizing collaborative, even into design build almost approach into this, right? To get this
It is
constructed.
it is a design build that we've done the design, but it's a turnkey process
Yeah.
of construction.
Of construction. And this isn't, again, like it may feel new for healthcare, and have been through these processes of creating programs, and a lot of it's been more MOB, right? That acuity level, that you talked about early on. Like there is a difference. But you're saying like, hey, we're just aiming to solve like 80% of those things that normally would be solved in a space like this.
Right.
Um,
So you know what? A lot of the things that have been ambulatory, there's been already the revolution in ambulatory
right.
care, right? The clinics, the ambulatory surgical centers,
Hmm.
all these ambulatory, the freestanding ED,
Right.
the urgent care facilities. These things are all good. These things are
Right.
all great. But when they have a problem, they can't admit a patient. There's no admissions in a freestanding ED. There is no admission that can take place in a ambulatory surgical center. If they have a problem, they have to go to a hospital. That's the
Hmm.
difference between a micro hospital and an ambulatory facility of any sort. We can admit patients. The most
Hmm.
serious one, we can treat and transfer, but we can admit patients. And
Hmm.
not only, I've said this, I'm getting a little off topic here, but
Right.
the
Right.
repeater system to the major hospital for that cardiac thoracic surgery, for that major hip replacement. No, we're not doing those in these hospitals. per se,
Mhm.
right? We're not doing cardiac thoracic surgeon. These are low to mid acuity hospitals. Higher
Mhm.
acuity is the major, and that's where these are feeder systems to them. But they also work the other way in a transitional care sense that in a major hospital, after somebody's had this cardiac thoracic surgery, right? And they're out of the ICU, they can be then transferred back to the micro hospital and be placed there at a lower cost, at a much
Mhm.
lower cost than the downtown unit for transitional care. These hospitals are local and they can provide personal care for people that are coming back. And they come back to the micro hospital and then they go home.
Mhm.
So, we see the economics of that working both ways.
Well, I mean, you said the joke, but that's the first thing I thought of. If you transfer somebody back, they'll be in the location where they're
Yes,
normally living and
closer
experiencing
to home.
life and community, and now that community is there to help them recover quicker, opposed to being 3 hours away and maybe somebody you've seen in the last 10 years gets to come visit. So
Yeah.
it does back to that human piece because coming from design and construction, like everything we do is for humanity. Like we
Well, yeah.
building infrastructure is about the humans. It isn't about anything else, right?
Right. I mean, hospital care and yeah, hospital. When people think about what if you're going to build a town, right? You're going to say, "Well, I need a fire department. I need a police department.
Right.
I need a hospital,
Right.
right? I need
Right.
schools." These are those resources, community resources that every community needs. Um,
Yeah.
again, we are not a complete solution, but we're part of the solution to a problem that exists.
Hmm.
And we think that again, if we can keep if we can lower costs, then we can make of things accessible. We're going for
Right.
and that being said, appropriate to a low to mid acuity hospital.
Right. Right.
All the high tech stuff that I did when I was working at Harvard hospitals or at the Cleveland Clinic and all that, very little of that goes into these hospitals.
Right.
Those are for the high acuity hospitals.
Yeah.
And there's a high low mix, and there should be a high low mix.
Yeah, absolutely. I mean, I don't I think I mean, yes, we all want like what we want, but like there has to be a solution that it's solving a problem and is not necessarily to have all of those things. And that's, as I'm thinking through this, I think, okay, as a designer, we all want our fingerprint on something. We all want some impact. And what you're addressing, it's like, okay, again, going back towards the problem exists, right? We know it exists and it's getting worse and worse. And I think, given a lot of the news that's out there, and I try to, avoid politics, but like there are a lot of changes that are about to happen that may make
Yeah,
this even worse for rural areas.
yeah, it's
Um,
It's
right?
true. It needs a standardized solution. Now, we'll allow people to customize it. I'll let you have, remember, I think it was Henry Ford said, you can have any color you want as long as it's black. Well, we'll allow you to have any color you want within our palette of the
Right,
hospital. And that's what you get to choose. And we'll allow you to choose your carpeting within our palette, within the carpet that goes in areas, the floor tile, we'll allow you to brand this so that
right,
it looks like your hospital. But it's a standard hospital. I have had people ask me if we can change it dramatically. And I've said, no, we really can't. It's
right,
just not there. I can change some certain things and we can customize and we can brand it, but it's the value of it is that it's standardized, that it's
right,
deployable, it's repeatable, it's scalable, and we can't get away from because that right blend of affordability and technology and scale is what makes hospital services accessible. That's what we think.
right. Yeah. Well, it- I'm enjoying the conversation because I think there's so many things that
You're
it can solve, right? That the rural areas, and I'll tell a story about, the one that was down I grew up in Marietta, Ohio. And that's in Southeast, it's a small city. They have a healthcare system. Well, they constructed a new clinic. It wasn't a hospital per se in that case, but there's procedures that are done there, but they used all prefabrication. It's based in Athens. They use modular construction because there is no labor force to even build, the facility. So one, I think about, areas like within Texas and a lot of other, regions within the middle part of our country where large cities are spread out, far away, and but there's still people living there. And they're just, as you keep alluding to, is this healthcare desert. Like, one, we know the problems there. The healthcare systems know it's there. The local states know these exist. And you said this before, but what does it look like or what does it mean if we don't solve it? They may not answer that question.
I think that people have a real right to health healthcare access, and I think that, that means hospitals also. It's not just ambulatory care. And part of that solution again is that we can say that we are not overbuilding, but healthcare systems also have to have their own targets of serving people. Their mission has to be to serve communities. I think there has to be some certain things to offer nursing and physicians and clinical staff incentives to work in these areas. I mean, there's always been those initiatives where young people going to medical school, nursing school, that the government used to pay a portion of their tuition, if not all of it, if they would then uh, give 3, 4 years to a rural healthcare program. MCP micro hospitals will not contribute to the problem. They will help sustain a solution for people for a long time.
I mean, there's a lot there to just kind of ponder and think about. The mentioning of the program in the past of, I think about even educators, right? Going to teach in a rural area, North Carolina. I lived there for a little while and they could not find teachers. They maybe still
Right.
can't. So like we have this, again, it's not uncommon that certain professions can't get the individuals to the location that's needed. But you mentioned again back to well, that's capital and that's finance and everything we need. That's always going to be true.
We
That is
need human
always going to
capital
be true
too.
for
Right. We
everything.
need
And we tend to build barriers up. Not just, I'm not saying you, I just mean as a society and as other humans, to just use that as I get out of jail card, if you will, of I don't need to think about this anymore. Well,
yeah,
that's not
we
solving the problem. And I think you've even said this isn't a silver bullet. So it doesn't mean it's for
yeah,
every location, everywhere. We're not aiming to solve every single thing, but there is someone who is probably out there listening that's like, hey, my community could probably use something like this. Right.
right.
And things like that. So I do think it's viable that could we rethink it? Like, well, you could shift staffing. Like, if they are located, people could be traveling a couple days a week. There's all kinds of ways to solve it because we have to do it in construction. We have to do it with every industry that we're in.
I was gonna say, we may want to make, it may be that we have to make, rural communities, a place that younger people want to go.
Hmm.
And why would they want to go there? They'd want to go there perhaps to have a family, and if they are going to have a family, they're going to want to have schools, they're going to want to have healthcare, they want to have jobs. It's the human capital. We talked
Right.
about financial capital, but it's the human capital. We have to attract younger people
Mhm.
and maybe give them incentives of housing, give them incentives to make sure that they can have viable jobs.
Mhm. Yeah, I mean, there'll be people who say it's a better quality of life that they want because I can't suggest that what I want is what everybody wants, right? And I think in
Sure.
in
None of us
i- i-
can.
all of us as from estates, and like we know affordability is a big conversation going on right now beyond healthcare. So yeah, I think there's a lot of ways to think about, and we are talking about building a hospital, but that's why they're so intertwined, because it's like it may be a hospital that has to be built, but there are so many other things that go within our communities of the
Right.
importance of solving this issue. Because if there is no infrastructure, if there is no housing, if there is no whatever, people can't go to that location.
Right.
Um, anyway, so it is it is a deep conversation. I mean, I'm just thinking through it, and it's what you're doing. Like I said, it's a unique model. It's packaging these things up in a way to solve a very real problem by utilizing things that we've all been doing and just coming up with a new sort of delivery to get it there quicker and address a lot of different things, a lot of different problems, accessibility, affordability, all those things you mentioned before. Um, we threw up what those barriers can be. But Peter, kind of a final question I have is around, you know, what do you think success looks like, not just from your standpoint, the modern clinical planning and what you're aiming to do, but like if you achieved it or if we achieved it as a society, like what from the healthcare, like what does that success look like to you?
I think success is affordable healthcare, right?
Mhm.
I think success is the well-being of people in their local community. I haven't used this phrase, but I've said it before. It's kind of the so-called Amazon model. We should be
Mhm.
bringing it to you. You
Mhm.
shouldn't have to go get it.
Mhm.
I think these small micro hospitals are the infrastructure that support healthcare delivery.
Right.
Uh, you know, Healthcare delivery is done by people, not by my building. But this is the infrastructure that supports that healthcare delivery. I
Mhm.
think with the wellness of our population, that we see trends that go to people living longer,
Mhm.
people not having as many issues of, coronary artery disease or people that have issues of diabetes that it's under control or that kids with asthma are able to be treated that people
Mhm.
can have wellness. That's the goal. That's the goal of having any hospital or any healthcare facility, I would think. It's
Mhm.
not to move money.
Mhm.
So, yeah, I think the goal has to be the wellness and to provide care, but knowing that it has to be affordable and at least not a loss.
Mhm.
And I think that it may even have external benefits. Again, we talked about, feeder systems and things like that,
Right.
that be viable.
Yeah. I appreciate you saying it because again, it's back to the human piece of it. The micro hospitals are a vessel for people to do what they need to do in order to make other individuals' lives
Right.
better. And, the food, we have food deserts, we have affordability of food, all it all ties back into our quality of life
Right.
as humans, right? Everyone that's around us is going to have a higher quality of life when we could solve the basic fundamental needs that we have as humans. And you have seen a problem through your life and you said, hey, it is unaffordable. We're over designing. I think you've gotten to
Right.
that.
Right.
We didn't get into value engineering, right? But the way you've approached it is to say, like, we are right sizing these based
Right.
off of things that we've learned, feedback that we've got in order to make it affordable to construct in a timely manner to get micro hospitals into regions that don't have it to solve a high percentage of the things that we need as humans on routinely, where we don't have to travel long distance and making it harder to gain that access like you said. So
It's the comfort, and you use the right phrase. It's quality of life. It's
mhm,
quality of life, right?
yeah. Yeah, I mean, hey, you're solving a problem I think we all can relate to. We've all talked about it. We talked about it my entire life. So ignoring it isn't working anymore.
No,
It isn't going
the
to make it go
problem
away.
never hurt.
Yeah, it is never going to go away. So the final thing then, for you, Peter, someone's listening. What is something, a next step or an action item that you think they should take to not just learn more about, what you're doing with, the modern clinical planning, but like looking and evaluating this problem deeper or talking to people in their community? Like, what do you think they could be doing?
Well, we've tried to do a little bit of education. I've done a number of posts and
Mhm.
that talked about the industry, that talk about the rural healthcare crisis in America, how Robert Kennedy Jr. Is in fact made a proposal for funding rural healthcare initiatives. We'll see how
Mhm.
that rolls out. Um, I think that yeah, please go to our website um, for modern clinical planning. You know, just research it a little bit, and you'll see that you know there's a lot of areas. And you brought it up a little bit, Ryan, where you said we're not so sure where things are going to be going in 2026. There
Right.
are fair number of cutbacks in funding, and those cutbacks can affect the quality and affordability of care. Um,
Mhm.
so there are things we can do, and we can move forward in a reasonable fashion. And I
Mhm.
think that's what we're trying to do with micro hospitals because again, I believe that they're the infrastructure that supports healthcare delivery.
Well, I really appreciate getting to have the discussion. It has definitely intrigued me.
Thank
Like I
you.
said, since I first saw what you were working on and knowing from my past a lot of the things that I was doing from construction side and prefabrication of like, hey, this is a unique model that is separate of, like you said, a proprietary solution that another healthcare system might be doing, but this could bridge a gap. I appreciate you sharing your story. I know you're fairly new in the journey from this side, from, the clinical planning side for your business, but you're not new to healthcare. So you're bringing a lot of experience and things that you've seen and continue to talk through. So I'm glad you were at this point in your career where you said, I've done a lot of work, and I am willing to dive into to solving this issue. So, Peter, thanks for being willing to be a guest here on
Thank you.
Activating Curiosity. You certainly continue to spark mine with a lot of the work you're doing. So, thanks again
Well,
for
thank
being
you
on.
so much. I appreciate being here.
So, that is the episode with Peter Nicholson with Modern Clinical Planning. And like I said on the episode, something struck me when I first saw some information come out on LinkedIn that he was posting that I knew I needed to have a conversation with him. And I'm hoping that all of you as listeners are as intrigued as I am, is that he is looking at how we design and procure and construct hospitals at a micro level in regions and areas and health systems where building a full facility would take multiple years beyond his planned solution. He is trying to take his experience and address part of the healthcare systems that most of us face. So he is trying to say there is this space in between that needs a solution that is not only affordable from the healthcare side, but it is affordable for people to get to because they're not leaving the region, and it is accessible. We identified potential obstacles that we probably all recognize and probably even think like, I don't know how to begin to address this, but that is why I wanted to have the conversation because, we still are human and need accessible healthcare when we need it. I hope you enjoyed this episode. I know it may have felt a little bit that we weren't talking as much about construction, but again, a lot of what we do in design and construction is about the humans on the other side and the spaces that we design and build for them. And that is part of our responsibility to be helping solve those problems. So until next time, I hope you continue to look at some of those challenges that you feel internally, I want to be a part of it, and I want to take that first action step towards solving it. I hope you're able to do that and continue to activate your curiosity as well as others in their curiosity.
The Activating Curiosity podcast is brought to you by Connective Consulting Group and Connective Coaching, part of the Curiosity Building Experiences. If you enjoyed today's episode, don't forget to subscribe so you'll never miss a conversation. Share the podcast with your network and help us bring more curiosity to the construction industry. Interested in becoming a guest or a sponsor? Visit us at activatingcuriosity.buzzsprout.com for more details. Until next time, keep leading with curiosity.